Hi everyone, welcome. We have a lot of people joining, so we'll just give them another minute or two. Okay, let's go ahead and get started. I want to make sure we have enough time for presentation and discussion. So welcome everyone to our second implementation science seminar series this year. Great to have you here. We see lots of new people here as well, so welcome. So today I'm really thrilled to welcome Dr. Alejandra Paniagua-Avila, who is our presenter. And I've known Alejandra now, oh my gosh, I guess maybe 3 years now. She is an amazing doctoral student at Columbia School of Public Health in the Department of Epidemiology, and she's been part of this group since the beginning. So it's made lots of contributions, and I've gotten to know her well. She does amazing work on really thinking about the development and implementation of chronic disease interventions focused on a range of issues, including mental health. I'm very happy to have her share her work. And I also want to just highlight and welcome Dr. Meredith Fort, who is here as well today, who is from the University of Colorado School of Public Health. I've also gotten to know Meredith in a number of ways in the last few years, and I've worked closely. I know she's worked closely in supporting Alejandra's work as well. So she's going to be part of the Q&A. So wanted to welcome Meredith as well. Okay, I am going to hand it over to you, Alejandra. Thank you so much for being here.
Thank you. Thank you, Dr. Shelton, for this opportunity. As Dr. Shelton was mentioning, I've been participating in these implementation science seminars for a couple of years now since I started the program. And it's just really nice and such a great opportunity to be able to be here now as a speaker. So today I will be presenting results from this implementation assessment of a hypertension program that's being implemented within the Guatemalan public primary care system since 2019. As Dr. Rachel Shelton mentioned, I've been conducting these assessments with the mentorship of Dr. Meredith Fort and also under the mentorship of Dr. Rachel Shelton, who is actually not one of the developers of one of the frameworks that I used for this assessment. So with that, I will like to get started. So I will start this talk by sharing some background about the implementation effectiveness trial that this implementation assessment is part of. Then I will go on to talk about how I selected and integrated the different implementation science frameworks that guided the design and the data collection and the analysis of this assessment. And I will end sharing with you some implications and some thoughts about implementation science research in low and middle income countries. So let me start by sharing a little about the double burden of disease in Guatemala. So the double burden of disease is a term that's utilized to refer to the coexistence of chronic and infectious diseases. This is really commonly seen in low income settings. And what this graph is showing is really the burden of disease in Guatemala. The blue section corresponds to the burden of chronic diseases, including ischemic heart disease, diabetes, chronic kidney disease. The orange areas correspond to infectious diseases and the green to injuries. And what we can see here is that really the burden of chronic disease has increased significantly over the past 20 years in Guatemala. What is important here is that hypertension is the most prevalent preventable risk factor for chronic diseases. Hypertension really underlies many of these chronic diseases like like ischemic heart disease, stroke, and diabetes. Unfortunately, although we know how to treat, how to diagnose hypertension, this evidence is really not reaching many of the low-income settings like Guatemala. And really, the health systems have not been able to keep up with this increase in chronic diseases. And so I wanted to share with you a really brief overview of the Guatemala's health system. The Guatemala health system is split into a private and a public system. The public system is administered by the Ministry of Health and Social Welfare, or MOH, and it really serves most of the Guatemalan population, close to 70%. the population that the Ministry of Health serves is really a really vulnerable population, given that this is the population that is uninsured, the population that lives in the rural area, mainly Maya and indigenous, and with limited access to healthcare in general. What's important is that most of the public health facilities don't provide services for hypertension. So this hypertension program is really one of the first efforts to start providing services for hypertension. This program is based on a program that was implemented in Argentina and that was proven effective. The program was adapted to the Guatemalan context through a year-long needs assessment and an upfront adaptation that consisted on multiple adaptation workshops and a process of engaging stakeholders. This happened during 2018, and in mid-2019, our team at the Institute for Nutrition for Central America and Panama, INCAP, started implementing the program within the public primary care system in Guatemala. However, as you all know, around 8 months after we started this program implementation, the COVID pandemic hit Guatemala in March of 2020. And this caused an important shift and rapid changes in the context in the health system where this program was being implemented. And it is within this situation, within this context, that we conducted this first implementation assessment. It is important to mention that this program and this trial really capitalizes on a long collaboration and partnership between INCAP and the Ministry of Health in Guatemala. While Guatemala and Argentina are both in Latin America, as you all know, the contexts are really different. And here I just wanted to highlight some of the differences in terms of the primary care setting, for example. So the first thing that we can see here is that the staffing is very different. In Guatemala, most of the staff within the primary care system are auxiliary nurses who are sometimes supervised by professional nurses. In Argentina, in contrast, primary care clinics have physicians, nurses, and community health workers. So this is really important in terms of the availability of infrastructure that is needed to provide the service. The national health expenditure is significantly lower in Guatemala, and the population in Guatemala also has a significantly lower income per capita, as you can see here. Importantly, the population in Guatemala is mainly, or at least half, indigenous, Mayan indigenous, and the challenges are that this is a population that has been historically marginalized and that has suffered from health inequities for a long period of time. But I'll just finalize this by saying that these differences in the context just gives us an idea of all the adaptations that we had to conduct in order to be able to implement the program, and how challenging it is to implement a program like this within this context. So what is the program that I've been talking about? So this is a multi-level program, and it's multi-level because it spans multiple levels of the Ministry of Health. It is delivered within the primary care system, but it also includes higher levels of administration. It is multi-component because it includes one core intervention in addition to 5 implementation strategies. Today, I will focus on the core intervention. So let me briefly explain what this is about. This core intervention consists of a protocol-based hypertension treatment, which corresponds to an evidence-based stepped care algorithm to treat hypertension. This algorithm was designed by the study team and the Ministry of Health. And while we try to make it really simple so that primary care physicians and nurses were able to determine treatment plans and guide their decisions about prescribing medications and combining medications, etc., it was really challenging because really before we started the program, most of the healthcare facilities where the program is being implemented were not even providing services for hypertension. And most of them didn't even have hypertensive medications. So we had to do an important upfront effort to make sure that the health districts were providing these hypertensive medications that are needed to implement the protocol-based hypertension treatment. This trial follows a design of a hybrid type 2 effectiveness implementation trial, a design that places the same level of importance to the effectiveness and the implementation outcomes. It is a cluster randomized trial with 36 health districts or study clusters, 18 of which received the program intervention and 18 of them received an enhanced usual care for hypertension services. These 36 districts are distributed between 5 health areas or departments as shown in the map on the right. And this trial has 2 co-primary objectives, one about clinical effectiveness on hypertension control, and one on implementation, which is the focus of this presentation. Here, I just want to draw your attention to the implementation outcomes and the sustainability outcomes, which are the focus of this assessment. So let me move now to the methods and frameworks. So from the beginning of the study, we were planning to utilize REAIM as the framework to guide the evaluation and the planning of the program implementation. And we were planning to utilize PRISM to look at the contextual factors that influence program implementation. While we were planning this implementation assessment, COVID hit the world and Guatemala, and it really highlighted the health inequities around the world, and it also posed a threat for the program sustainability. And for this reason, we decided to integrate this REAIM extension for sustainability and health equity developed and published by Dr. Rachel Shelton last year. So let me just share with you a little bit about each of the frameworks. So PRISM and REAIM are usually used together, as I'm sure most of you know here. And PRISM focuses on the multi-level context. And I'll just highlight a couple of things here. The implementation and sustainability infrastructure, which is basically what needs to be in place in order for the program to be implemented. And then the fits between the program and the context is really how the program is made for the context and how the context is really made for the program. That's how I understand it. In terms of REAIM, REAIM focuses on the program implementation, and it also focuses on how and why the program is being adapted. Now, the REAIM extension to enhance sustainability adds a few things to PRISM and to REAIM specifically. First of all, it understands that programs evolve over time and that they will undergo multiple adaptations. It also understands that programs are implemented within a dynamic multi-level context that will keep evolving over time. It gives explicit consideration to equity across the multiple components or dimensions of REAIM, and it focuses on the dynamic sustainability of this from the start. This dynamic sustainability means that we not only care about institutionalization as an end, but we also understand that the program sustainability is something that's dynamic and that changes all the time. It recommends that REAIM is applied iteratively, and it also recommends that this framework is combined with other frameworks that focus on the multi-level context, like PRISM. That's what we did. So this is how our integrated frameworks look like. PRISM evaluates the multi-level dynamic context, specifically the organizational level and the community level. REAIM evaluates the program implementation and specifically the program adaptations, while REAIM for sustainability is a framework that provides us with the lenses of health equity and sustainability to look at the context and to look at the program adaptations. So Selecting and integrating these frameworks in this way allowed us to refine our implementation assessments. So these were our 3 implementation assessments for this study. The first one was to really identify and understand the multi-level contextual factors that may influence program implementation pre and during COVID-19. Second, we wanted to identify patterns of program adaptations in response to contextual factors, again, pre and during COVID-19. And third, we wanted to draw implications for sustainability and health equity in relation to context and program adaptations. And I'm just including here our framework so that you can see the relationship between the aims and the frameworks. This assessment was conducted in 5 of the municipal health districts that are receiving the intervention program. These districts are distributed within 3 different health areas or departments as shown in the map on the left. And just to show you how a health district looks like, health districts are composed of a municipal health center as the one on the left, and they have multiple health posts as the ones on the right. But for this assessment, we only included the health center and 2 of the health posts. We interviewed 18 key informants who were participants that were highly involved in the program implementation, and they included staff from the Ministry of Health, as well as research staff from INCAP. And the participants were working at different levels of the healthcare system, including the health districts, health areas, and also at the community level. The multi-method assessments consisted on a combination of qualitative and quantitative methods. We started by conducting semi-structured interviews with key informants, as I mentioned. All of them were phone-based given the travel restrictions due to COVID that were in place at that time when I was conducting the data collection. And then for the qualitative analysis, I conducted a rapid identification of themes, which is a method that allows you to identify themes directly from the interview recordings instead of having to transcribe each of the recordings, which is what's usually done in qualitative research. So this allowed you to get at results more rapidly. After creating some interview notes from this rapid identification of themes, I conducted a matrix-based thematic analysis following the implementation science frameworks that I mentioned before. After conducting and analyzing the qualitative data, we utilize this qualitative data to select some quantitative indicators of implementation collected at the health facilities. So something that's important here is that we were interested in collecting this qualitative data because we really care about the perceptions of the providers and who are really involved in the program. But also we were kind of forced to do this qualitative data collection and analysis before the quantitative because COVID really had suspended the quantitative collection of data. And so we waited for the lockdowns to be lifted and the quantitative data to be collected and to go back and to analyze this quantitative data. This is just to give you an idea of the data collection in the context of what was going on with the COVID cases and the restrictions in Guatemala. So the data collection happened a couple of months after COVID hit Guatemala, in the middle of one of the COVID peaks, as you can see here, and just a few weeks after the temporary lockdowns were implemented. So now let me move to the results. So let me start by sharing with you the main qualitative themes that we obtained. So as you remember, this is the diagram that shows our integrated implementation frameworks. And so, of course, our qualitative themes were really similar to this figure. The only difference is that now we not only had information about one dynamic context at one moment in time. We now had information about this dynamic context pre-COVID and also during COVID-19. So we were able to see how the context was changing over time as COVID was affecting the health services in Guatemala. In addition, we also have information about the program implementation and the adaptations that occurred before COVID and the adaptations that happened during COVID-19. And finally, we had the lenses of equity and sustainability to look at the context and to look at the program adaptations. This is just another way to look at it, at the qualitative themes. So we have the main qualitative themes, the multi-level dynamic context, and now we have some sub-themes here. So let me just point here at a couple of things. So within the multi-level dynamic context, we looked at the fit between the health district and the program, and we also looked at the sustainability infrastructure. In terms of the program implementation and adaptations, we looked at the delivery of the program and why and how the program adaptations happened. When we combined results and themes from this dynamic context and the program adaptations with the lenses of sustainability and health equity, we were able to draw implications for sustainability and health equity. And this is what we see here on the right column. And something that I wanted to mention is that the publication by Dr. Rachel Shelton on this extension of REAIM was really helpful to guide this analysis on the right side. And these are some of the questions that are included in this paper by Dr. Shelton. For example, what contextual factors matter for sustainability? What contextual factors matter for an equitable program implementation? And the same questions about sustainability and health equity, but for the program adaptations and the implementation strategies. So now let me share with you some of the results. Starting with the multi-level dynamic context, I wanted to share with you some results around the fit between the health districts and the hypertension program. We found different barriers for these fits, and I'll share some of these sub-themes with you and some quotes that exemplify really well these themes. So first, we found that an important barrier for the program implementation is the competition of the program with other primary care programs. One of the data collectors said, "You cannot predict when a child will have an undernutrition emergency." Vaccination campaigns and maternal and child health programs were always prioritized over the hypertension program. We found that COVID enhanced or made some of these barriers even worse than before COVID. So when COVID hit Guatemala, some of these COVID activities related to the COVID response were added on top of the 22 other Ministry of Health programs, in addition to the hypertension program. Another barrier was the insufficient and overburdened healthcare staff. So before COVID, the staff was already insufficient. This health area administration shared, "We don't have enough staff. We should be hiring more staff, and we should request that we continue with the program," meaning the hypertension program, "because it has improved our knowledge. We're learning something new every day." After COVID, the same happened. COVID enhanced some of these barriers. One of the health area administrators shared with us that the staff was responding to COVID-19, but the number of workers had not increased. They are tired, they have not taken vacation, there is staff that is in isolation, and some of them have been sick. A third barrier was the temporary suspension of services due to COVID. So in addition to having competition with other services, in addition to having insufficient and overburdened healthcare staff, the services were temporarily suspended because of COVID, because of the lockdowns that were happening in Guatemala. One health administrator said, "Now 2 of our health districts are closed. They are paralyzed because the staff is infected. And this is going to take at least 14 days. It is really hard to follow up patients who are enrolled in the hypertension program." Another providers shared. There's been lockdowns, checkpoints, transportation has been suspended, patients cannot visit us, and we cannot visit them. We only found that there are some facilitators, some contextual barriers that really facilitate and really favor the fit between the health district and the hypertension program. One of them that's really important and kept coming up in our interviews is the role of program champions and the role of strong leadership. This health district nurse shared, the doctor, our director, she energizes us. Other ones would say, let's only do this program for some time. But she motivates us and we motivate the auxiliary nurses. Now we're also seeing diabetic patients following the principles of the hypertension program, and the rest of the districts are also following the same program. Team collaboration and communication was also really important, and it allowed the team to not only implement the program before COVID, but also to adapt and to implement the program when COVID happened. These data collectors shared. When COVID started, nurses were able to take the doctor responsibilities and continued with the program. This happened in a district where there was a health district director with strong leadership and who really supported the program. Finally, I'll just mention really briefly that the health districts that had previous chronic diseases programs, or at least were beginning to provide hypertension services, seemed to have an easier experience implementing this new hypertension program. So this is about the fit. Now let me move to the implementation and sustainability infrastructure. As I mentioned before, this refers to what needs to be in place in order for the program to be sustained, and this is part of PRISM. We can see here on the left the different categories of sustainability infrastructure. For the medication supply chain, one of the health areas nurses said that having medications was really the first thing that needed to happen in order to be able to implement the program, even within the new reality of COVID. Having essential equipment and essential supplies like blood pressure monitors was also key and kept coming up in our interviews. Human resources, this was described by multiple health providers and administrators as the main challenge to implement the program. The need to having a supervisory team from the Ministry of Health in addition to the research team, because what happened during implementation is that the research team really had to take on the roles of coordinating the program implementation, supervising the program implementation. But a lot of the participants highlighted the importance of having a team from the Ministry of Health. And finally, the importance of having indicators that document the implementation of chronic diseases program. This was highlighted by multiple of them as a barrier to implement the program, but it was also highlighted as a facilitator for in just one of the health districts. They mentioned that they were already collecting indicators related to chronic diseases, and for that reason, it was easier for them to implement the program. Okay, so now let me move to the program adaptations. And here I will only focus on the core program intervention, which is the protocol-based hypertension treatment that I described at the beginning of this presentation. So let me share with you one of the examples of one of the quantitative indicators of program delivery at the healthcare facilities. And this is the availability of hypertensive medications at the health post. This is an indicator of the program implementation because it is related to the step care hypertension algorithm. As I mentioned, before the program started, most of the health facilities didn't have hypertensive medications available. And so we had to go through a really significant effort to work with the Ministry of Health and ensure that the health districts were providing these hypertensive medications. So this really highlights that the stepped care, the protocol-based hypertension treatment is being implemented at least at the healthcare facilities because the medications are available. And of course, we can see a wide variation of medication availability going from 45% to 93%. But this shows how the program, this really shows the extent of the program implementation. What the quantitative indicators cannot tell us is really why is it that some health districts are showing different levels, different extents of program implementation. And this is what the qualitative information can help us with. So let me share with you some results around the program adaptations, again, related to the protocol-based hypertension algorithm. And here, let me share with you this theme about availability of hypertensive medications, which is something that kept coming up multiple times during our interviews. Health District North, for example, mentioned that before the program started, they only had enalapril, and they only had it available at the health centers. Now we have 3 different medications, and it is motivating our patients to participate in the program. Now, COVID complicated the availability of hypertensive medications and led to program adaptations. This nurse, for example, described that they had been requesting medications, but they were not getting them. It is very sad to tell patients who are afraid of visiting us that we don't have the medications. However, we shouldn't just blame COVID, because we've had this problem of medication shortages before, even before COVID. In terms of access to hypertension medications, a lot of the districts adopted different program adaptations to be able to facilitate access to hypertension medications. Before COVID, for example, some of the health districts moved the delivery of hypertensive medications from the health center to the health posts. Health posts are closer to the communities, so this facilitated the access. After COVID, there were additional adaptations that were made to the delivery of these hypertensive medications. For example, auxiliary nurses started delivering medications for supplies of medications for longer period of time, for 2 to 3 months, and this was done to reduce contact with patients. They were also authorized to deliver the medications to relatives, and they began bringing medications to their houses of participants that live too far from the health facilities. However, they mentioned that it was really hard to deliver medication to those who didn't have a supportive relative, those participants who lived on their own, on those who live, and also some other healthcare providers mentioned that it was harder, of course, to reach those patients that live far away from the health posts. So now let me move to the implications for health equity and sustainability. And this is the last section of the results. Sorry, I'm just getting some notifications in the chat and I'm getting distracted. But this is the last section of the results. So as I mentioned before, these implications for health equity and sustainability were guided by the extension of REAIM for sustainability. So let me share with you first some implications around sustainability. In terms of the multi-level and dynamic context, we saw that COVID really exacerbated some of the contextual barriers to program sustainability. For example, not having sufficient staff, problems with the medication supply chain. And really what COVID did is that it reduced the fit between the program and the health districts through these additional barriers to implementation. However, we also saw that those health districts that had more sustainability infrastructure before COVID were able to continue delivering the program even during COVID-19. Some of these factors that were really important were having program champions having strong leadership, having team collaboration, and clear delegation of responsibilities. All program components underwent plant and organic adaptations, and in this presentation, I only talked about one of the components, but all of them underwent different adaptations. Some of these components and some of these adaptations seem to be more sustainable than others. So, for example, one of the components that I didn't touch on was the home-based measurement of blood pressure, and this was really complicated, given that most of the participants, the program participants, have really low levels of literacy. So it was really hard for them to meet with this program component. So this is probably one of the components that will not be sustained in the long term. And in fact, it's already been suspended in many of the health districts. And I just wanted to share that evaluating the program implementation and really looking at the implementation of the program allowed us to draw implications for sustainability. And what I am trying to say here is that a lot of the time sustainability is evaluated at the end of the program implementation, but here we show that by looking at the program implementation, we were able to start thinking about the program sustainability and start thinking about how to adapt the program to be able to make it more sustainable. In terms of health equity, we saw that the program delivery and the adaptations differed by health district. And this was due to multiple reasons. One of them was the availability of sustainability infrastructure. We also saw that some of the adaptations may enhance equity. For example, moving the delivery of hypertensive medication from the health centers to the health posts, while some other adaptations might widen these health inequities. For example, some of the health providers mentioned that they were doing some phone-based scheduling to deliver the hypertensive medications, but this was not possible for those patients who didn't have a smartphone, and they were not able to answer the phone. In terms of health equity, we also saw that there will need to be some adaptations done to the program in order to be able to reach some of the subgroups of patients that the participants identified as harder to reach. This included, for example, male workers that worked in the agriculture, those who live far from the health posts, females who are not allowed to participate in the program by their husbands, and those participants who lack social support. It is important, what we learned is that it is really important to have an explicit focus on health equity. And I am highlighting this because our program always had an implicit focus on health equity. But when we added this additional lens of health equity, we were able to identify some patterns of health inequities and also to identify some program adaptations that might help us address some of these inequities. Now, I will just finish by sharing with you some implications and next steps for this program, and also some implications in terms of conducting implementation research in low-income settings. So in terms of the implications for primary care programs for chronic diseases, to me, the most important finding of this assessment is really this competition between the evidence-based program that we were implementing with the rest of the programs within the Ministry of Health. And this is really important because a lot of the times in implementation science, intervention research, global health, we focus a lot in evidence-based interventions, but it is really hard to implement an evidence-based intervention when there isn't enough sustainability infrastructure and when there isn't a real fit between the intervention and the context. So this highlights the importance of really evaluating the context and really taking into account the context in addition to the evidence-based intervention. And this is also related to this idea of really strengthening health systems and the other perspective, which is focusing on vertical evidence-based programs. So this implementation assessment and the experience with this hypertension program show that really strengthening the system by, for example, ensuring that hypertensive medications are provided within the healthcare settings, really facilitated the delivery of the program. And without having done that, the program would have not been able to be implemented. In terms of implementation research in low and middle income countries, I just wanted to highlight that this research often looks very different in low income countries compared to high income settings. And so this is in some ways because a lot of the implementation frameworks, a lot of the implementation measures really don't fit within the context of low and middle income countries. And so, but however, we are able to utilize 3 different guiding frameworks in a flexible way, taking specific dimensions of each of the frameworks and integrating them together to guide this assessment. I just wanted to mention that there is usually a trade-off that I realized with this assessment, a trade-off between having rapid results and in-depth qualitative results. And this seems obvious, but I am mentioning this because while we were able to obtain rapid results through the rapid identification of themes from audio recordings, really to be able to conduct an in-depth analysis, I really had to go back to the original interview notes to be able to get at the results that I'm presenting here today. In terms of next steps for this research is really to start thinking about how to combine implementation science with system thinking methods. And this is really just to facilitate making sense of all these detailed qualitative data and to really understand how these dynamic multi-level contexts change and how they influence the implementation of programs. And of course, the next step will be also to link some of these implementation results to the effectiveness outcomes when these outcomes are finalized. So with that, I would like to thank and acknowledge my mentors, others who participated in the analysis, my DRPH practicum supervisor, and of course, all the implementation assessment participants and the program adaptation team. So thank you very much, and let me know if you have questions. I'll stop sharing my screen.
Amazing. So exciting to hear all of this. I think I'll just highlight a couple things and then open it up for questions. I'll say I love how you gave the examples of operationalizing all those frameworks. I think that that's something that people really struggle with, and this is such a nice, clear example of how you have brought in those frameworks in different ways. So that was so helpful. And I also feel like it's so amazing how you've highlighted the different aspects of context, both kind of the pre-implementation and implementation, and then what was different in terms of COVID, and then what that will look like moving forward. So I know that this is something that so many people are struggling with. So I really appreciate that lens too. So amazing job. Thank you so much. Okay, I see we have some questions. So Joanne asks, what if any effectiveness outcomes do you suspect will be linked to outcomes from implementation research?
Okay, so let me read this again. So what if? So well, the main effectiveness outcome is hypertension control. So, and maybe Merit can also share about this, but definitely I think that hypertension control is going to be linked to the availability of hypertensive medications. And also there is another clinical effectiveness outcome, which is medication adherence, which is really challenging to measure everywhere, and especially in settings like this one. But I think that is also going to be related to some of the implementation outcomes, such as the availability of hypertensive medications and some of the adaptations that were made.
Yeah, maybe I'll just add to that. the team realized early on, because of what we found in the needs assessment of that lack of access to medications, that was going to be something really important to assess repeatedly. So there's actually a monthly assessment of that happening. So it's kind of a mini ongoing contextual assessment, because we recognize that without medications, it's not possible to be able to implement the program. And that's always, I guess, a kind of a question, in thinking about implementation science projects of this kind, when you have that level of scrutiny that's going on, and then of course it doesn't continue afterward, if that's kind of a strategy of implementation as well, even though it was really a data collection mechanism that we were using to be able to understand changes that were happening in the context. But I think that, as Alejandra said, is really going to be one of the key ones.
Thank you for that question, Jen.
And it looks like Sam's question is in the chat. Sam, I'm sorry you're not able to unmute yourself, but I can read it. This was amazing and a great explanation of how you are often unable to interpret quantitative results without integrating qualitative work. I wanted to focus on the competition with other health programs. There was a lot of attention and investment in chronic malnutrition in Guatemala in the past decade. Do some of your results indicate unintended consequences of those efforts or lessons learned for implementing similar large national programs in the future? That's a great question.
Such a great question, and it's really this is really what we've found with this assessment, and that is what I was trying to refer to at the end, where I was talking about this competition with other programs and how it is really hard to try to implement vertical evidence-based interventions, even when they have the best intentions, because what ends up happening is that a lot of the efforts, a lot of the resources, a lot of the human resources are dedicated to those vertical interventions, and that shifts the attention just towards those vertical interventions. And I am not against evidence-based interventions, but I think it's really important to start thinking about how we can look at the system and try to identify leverage points within the system to be able to improve multiple health outcomes and not only one specific outcome. And so, yeah, I'm not sure if this particular program led to unintended consequences, but I do think it's important that a lot of the participants did mention that the priorities in most of these healthcare districts were really to provide services for maternal and child health programs, including under nutrition. And that was one of the problems, and that was one of the main limitations, challenges to be able to implement this program. So thank you for that question, Sam.
That's great. It says, it occurred to me that the focus on indicators could have always grown out of the Zero Hunger Pact and similar efforts because they were so focused on indicator-based monitoring and evaluation.
Yes, I think there's a lot of and there's a lot of other information here too. And for those of you who are not familiar, this was a program that was implemented around 8 years ago in Guatemala and led by one of the presidents in Guatemala. So there's also a lot of political influence here, because this was the program, the public health program of one of these presidents. But it was also a government that had a lot of corruption problems. And so, yeah, there's also a lot of political issues here. But thank you for that question, Sam.
Any other questions? And I agree with that point. I mean, we so often, when we are doing the hybrid one trials or focusing on effectiveness, we so narrowly focus on that one program, not thinking about the broader context or thinking about the intersection, like you said, or leverage points within the system. And I think especially in settings that have lower resources, we have to be thinking about that intersection much more, because they never are existing in isolation.
Yeah, I think to me that's the most important finding of this. I'm not sure exactly how to do it, but with Meredith, we have been talking about beginning to utilize system science to really look at the system, right? Because we conducted this qualitative, in-depth needs assessment at the beginning of the program to be able to adapt it. But then a lot of the times with all of this qualitative data, it's really hard to put it together and to make sense of it and to identify the best places in the system to intervene on. So that's one of the things one of the methods that we've been thinking that could be helpful for this.
Mm-hmm. And you all should connect with Claire Green. I don't think she's on here, but she recently published a really amazing system science modeling approach with a focus on sustainability. So it might be good to connect with her too.
Yes, yeah, that paper is great. I also shared it with Meredith.
Oh, good.
Yeah, thank you.
Any other questions people have while we're on?